Good afternoon. My name is Veronica Williams, and I have the honor of serving as the president of the Willamette Women Democrats. We are very excited to be welcoming State Representative Dr. Lisa Reynolds and Heather Jefferis to speak with us about mental health in our youth. I'm very glad you could join us. As COVID-19 continues to present our communities and place a strain on our hospitals and wonderful healthcare professionals, we will continue to bring you our programs via Zoom. A few housekeeping matters. As you have joined us, we have muted your speakers and turned off your videos. We do this to improve the overall quality of the transmission of the program and to help ensure that our speakers will not be interrupted by accidental noises at your end. So unless I specifically call on you, please stay muted and with your videos off. Please feel free to put any questions for our speakers in the chat. After their remarks, we will be introducing elected officials and candidates in the room. Then we will get to your questions. If you have not yet had a chance to renew your membership or join for the first time, it is not too late. Membership and PAC information can be found online at W2D's.com. Your membership makes these Zoom programs possible, and I thank everyone who has already sent in their renewal or has joined for the first time. In addition, your contributions to our PAC make it possible for W2D to support state and local candidates in important races coming up in May and November. Last week, our state legislature began what is referred to as the, quote, short session. Originally designed to basically deal with budget adjustments and to, quote, clean up minor issues from prior year sessions. In the past years, this even year session has taken on some tough topics. Restricted by law, the session must end on March 7th. So it is a sprint to the finish from day one. If you are not already on your state representative and or state senator's email list, I encourage you to sign up and keep up to date on all that is happening in Salem. You can do so by just Googling their name and pulling up their legislative website and then signing up for their newsletter. At this time, I am pleased to introduce our program committee chair, Nancy Murray, to introduce our guest speakers. Nancy.
Thank you. Good afternoon. Dr. Cragen Usher, a specialist in child and adolescent psychiatry and an OHSU professor of psychiatry, said on OPB's Think Out Loud last fall, "We are living in a state of hypervigilance where danger seems to lurk just around the corner. The stress," unquote, "the stress and anxiety we all feel is acute in our youth." We have two speakers today who have a wealth of experience dealing with a spectrum of mental health and behavioral health care issues that have existed in Oregon for quite some time. They do complementary work that is difficult but necessary work to improve the health outcomes of our youth today. Representative Lisa Reynolds is a pediatrician at the Children's Clinic in Southwest Portland and treats patients from birth to young adults. As she treats their medical needs, Lisa sees up close the impact of mental illness, poverty, gun violence, and inequity on children, teens, and their families. She sees what is and what isn't working for Oregon families, and this influences the work she does in the legislature. Of particular importance is expanding affordable healthcare coverage for all Oregonians, expanding access to behavioral health care, both in schools and in clinical settings, addressing gun violence and houselessness, all of which directly affect our children's well-being. COVID, of course, has exacerbated all the above issues, making the impacts of school closures and in-person restrictions on services extremely challenging for our youth and their families, teachers, counselors, and service providers. On her website, Lisa talks about her brother's mental illness that has greatly influenced her as both a doctor and a legislator. During last year's legislative session, she served as a member of the Behavioral Committee,
I have USA supplement like.
as well as Vice Chair of the Early Childhood Committee, and of course was a resource for our state's response to COVID. Lisa was raised in Chicago, earned her bachelor's degree at the University of Chicago and her medical degree at the UCLA School of Medicine. Lisa's activism has led her into politics, where she now represents the Portland West Side, but because of redistricting, she will be a candidate for District 34 in North and East Washington County this November. Welcome, Representative Reynolds. Heather Jefferis is Executive Director of the Oregon Council of Behavioral Health. The council has a membership of not-for-profit and private providers in Oregon. They represent the entire behavioral health continuum of care, from prevention through residential and detox. The council not only advocates for legislation in this field, but also promotes public awareness of behavioral health prevention and treatment, which is a good reason to invite her to speak with us. Heather has an impressive background in this arena of mental health care, dealing with not only the usual functions of a director, such as policy planning, budgets, funding, and oversight, but she's worked also locally, for example, in the Clackamas County Circuit Court as a treatment coordinator in what the layperson might know as drug court. She also has experience working with school-age children at the Lynn Benton Child Advocacy Center. Heather received her master's degree from Melhurst University, where she was later an adjunct professor teaching child development theory and practice. She received her Bachelor of Science degree from Portland State University. Welcome, Heather Jefferis. And I think Lisa Reynolds is going to start us off. Welcome, Doctor.
Thank you. Thank you all for having me. It's nice to be here with you all. I remember back in late 2019 and early 2020 when I would join these meetings in person and the nice cheese plates and stuff. I mostly miss seeing people, but the food was really good too. So it's really an honor to be here as a state representative. Look, we all know that our behavioral health system is broken. We all hear these statistics. I don't even know where we are in the ratings. I know on treatment for addiction, Oregon is among the last in the country. On access to behavioral health services for adult and youth, we are very low compared to the rest of the country. Our needs are high and our services are low. And one thing I will say is recognizing this kind of in a more on the ground way as a pediatrician in the exam room, it made me feel like maybe I can do more on this issue than what I can accomplish patient by patient or in this room with this family. And it was one of the motivating factors, our broken behavioral health service that kind of motivated me to run for office. There's other reasons too, of course, like the importance of having people with healthcare and behavioral healthcare experience at the table making decisions on this. A third of our budget goes to healthcare, and these were decisions I made before COVID hit, which of course influenced all of that as well. I will say right now, and I don't want to say too much because I mostly want to hear what's on all your minds and how I can maybe provide my perspective. But I will say that there's been, I think, the workforce issue is real. We've been hearing about this in many sectors. We've also been hearing that the nursing shortage, the childcare shortage, the behavioral health care shortage, sure, blown open by COVID, but it was there before COVID. And it's in part with how we have treated and paid these workers. I think there's something to be said about government accountability. We need to be doing better on that, especially in light of the fact, something I'm proud of, that the 2021 legislative session invested transformational amounts of money in our behavioral health system. And I can list all the things at some point that we kind of attached to that money. But I will tell you today, from the day the checks were cut in July or whenever that happens to today, it is no easier to get access to mental health services in Oregon. And I think it should be going more quickly than that. And I would say, Nancy, quoted my website. I have a severely mentally ill brother, Pat. He was diagnosed when I was in college. And Ron Wyden actually shared, and I knew Ron Wyden has a brother suffering from schizophrenia, which is my brother's diagnosis. I think about him every day and I worry about him every day. I talked to him last night. He's doing okay. He lives in a nursing home in Chicago. His life has been so incredibly curtailed by his illness. And he is very vulnerable to both psychiatric breaks and physical disease because of his illness. And I would like to beat a drum that we need to talk about a cure for mental illness. Like, no one talks about a cure for mental illness, and it's very upsetting to me. And I know that I'm kind of part of the problem, because until recently, I didn't talk about the fact I had a brother who was schizophrenic, right? And I think about the fact if my brother had kidney cancer, I would probably be posting fundraisers and giving the update on what's the latest on waiting for a new kidney or whatever it is, right? I would be sharing about that. I would be rallying my community around my brother. We don't do that. There's still shame and stigma around mental illness. And that's why I think it's important we talk about things. So I want to stop there just because I want to have more time for questions, but I'm here to answer all of it. So thank you so much.
Heather, could we get you unmuted? And
Sure.
thank you.
Oh, thank you so much, Representative Reynolds. I just have to say that being an individual who has the privilege to lift the voice of behavioral health providers across the state of Oregon, Representative Reynolds is always a compassionate ear and an advocate for our sector and for the people that we serve. So thank you so much for your words today. Really appreciate it. And I concur. I think many of us don't have to reach too deeply into our family and friends to know people who have been impacted, myself included. And because of stigma, stigma is still here with us, and it makes it very challenging for folks to share those stories and to move the needle on improvement. And yeah, where is the cure? Where is the cure for these brain diseases that people struggle with, just like any disease in any part of the body? So thank you so much for having me here today, and I really appreciate the introduction. Thanks to Nancy and Veronica. Really, thank you so much. So I was asked to just kind of provide some level setting knowledge about our system and where we're at as a representative of the continuum of care across Oregon. And so a few things that I would like to share with you today is just a little bit about access, and also some thoughts around people often think the system is very confusing. And after talking about the system for 25 years, I wouldn't say it's so much as it's confusing, is that its variety makes it complex. And I think that you can intersect with one piece of the behavioral health system, and that is the only piece that you're aware of, because we have so many different pathways and so many different professionals and so many different types of training in behavioral health that it really is not a one-stop shop. And I think that gets back to stigma. A lot of times when people think about behavioral health, they think about us as psychiatrists and master's level clinicians, but actually the field is really a team-based care model. And there are so many points of entry and so many different specialties. So it is really in so many different payers and so many different oversight bodies. So it makes it a very interesting system to try and improve and support and enhance, because there are many different moving parts to the entire system, and it also makes it difficult to access in general. So that's one thing I would say about behavioral health. You know, if you have a loved one who has ADHD, you're going to go to a very different professional than if you have an individual who has post-traumatic stress disorder or schizophrenia. Those are specialty trainings, and so your concept of what's available and what's out there could be very different based on the needs that you have in your own family or with your loved one. So that is one little thing I always like to bring up when we talk about behavioral health, is just like medical profession, there are many, many, many specialties in the field. But unlike medical profession, I think stigma has often kept that very covered, and people are not really aware of the consumer opportunities that they have to have choice in how to shop for a professional. So I'll just overlay what I have to say with that. But in regards to really level setting where we're at in Oregon with children's services, and I'll focus on that specifically today, is that it is a very difficult time. As mentioned earlier, we really had a workforce crisis that predate COVID. And then we also had the COVID crisis. And unfortunately, these two things combined to create a really monumental struggle within the system. And as we know, even I think in physical health, most professionals lean into services for working with adults. It always is a struggle to recruit people to work with families, because family work is complex, and with youth and children, because that also requires extra education around child development, along with the specific area of interest that you would like to treat as a professional. So it makes it a complicated field to recruit in. People tend to lean into adult services more than they lean into youth and family services. And as Dr. Reynolds mentioned, those services historically for youth and families were not as well funded, supported, or prioritized, which then makes it less appealing, again, for folks to be recruited into that field. So long before COVID, we had a lack of access to trained professionals for youth, children, and family in the state of Oregon. And that happened on both sides of the service system. And when I say both sides, I mean the Oregon Health Plan public side and the commercial insurance side. So there was a real lack of access to care on both of those fronts, and there remains to be so. Some numbers that are really terribly terrifying and tragic to me is in the last 18 months, because of the COVID crisis, on top of this longstanding workforce problem that seems to be getting worse every year and year, we've had losses, catastrophic losses to residential access for mental health services and SUD services. Director Steve Allen, who is a wonderful advocate for our system and is over the behavioral health unit at the Oregon Health Authority, did an excellent presentation to the Joint Ways and Means here just a while ago. So I'm going to use a little bit of his data to share with you. Originally, in the state of Oregon, we had about 200, just to give you a little scope of the scale of loss that we've had in the system. We had 280 psychiatric beds in the state of Oregon for children and youth. And we have lost, oh gee whiz, where'd my number go? And we have down now to 91 beds in the state of Oregon. In the state of Oregon, in my membership, because most of my members are the folks that do residential substance use disorder and outpatient substance use disorder for youth and families, we had 134 licensed beds, which again, population of 4 million people, not a huge amount of resource, even in the good days. We are now down to less than 35, around 35 to 40 operational beds in the state of Oregon for youth in need of substance use disorder treatment, which is quite terrifying with our, as we all know, with our opioid, heroin, and fentanyl crisis that we have in the state. We really are at a point where we need to rebuild the system. And it takes leaders like Representative Reynolds and so many other champions that we have in the state legislature to really prioritize this. And we didn't get here overnight. We really have to work closely with our educational institutions, maybe perhaps take a look at vocational training opportunities and streamlining education, so many different options to recruit workforce, because we are fortunate in the modern day that we do have team-based care. So that means that we can recruit peers, CADCs, other people that provide services in behavioral health, particularly at these congregate programs, more rapidly. Those education credentials usually take between a year and 16 months versus having to have a master's degree. But at the same time, we also have to be lifting master's folks because we need a combination of professionals to deliver team-based whole family care in the behavioral health sector. So that is not good news, I know, but it is really important for us to think about when we see that we don't have access for youth and families in a immediate way. Those numbers really help it put it in perspective where we're at across the system today. We also see that our outpatient services also are losing staff, and so that makes it even more difficult for people to have some kind of support while they're waiting for the few beds that are available for them if they need a residential level of care. So with that, that's a little level set on the system. And I would say that we know that there's been huge investments, and we hope that those investments can be pushed into also lifting the youth and child and family services. But there's also great need in the adult system, though the youth system has always been much smaller, more fragile, and in more need of support. We are very excited about investments that are happening in the schools and hoping that we can really do an all-force push to move forward prevention and parenting supports along with clinical treatment, because not only clinical treatment is important, but it is really should be the last part of the story, not the first part of the story of mental well-being. So there's a variety of things. So again, I would like to open it up to questions because I could talk all day, and I would love to hear what you have to say or questions that you have about particular parts of the behavioral health system and things that we can lift. We are very excited in this current session that there is a piece of legislation, 4004, that is looking to move forward that will provide emergency funding to behavioral health providers. That piece of legislation will give us some retention bonuses, some ability to improve some wages, and also to recruit workforce. I was also very privileged. OCBH is working on a workforce campaign. So we are partnering with Care Oregon, which is a public plan here in Oregon in the metro region for OHP. And they have supported us to do actually a statewide workforce campaign to recruit workers with streaming ads and video clips and all kinds of exciting things. So we're really looking forward to that. And then of course, our members are always every day finding innovative ways in their community to recruit, train, and increase access with the workforce that they have at hand and encourage people to join. So those are a few of some exciting initiatives that are going on. I think those things are not totally new, but every little piece that we can leverage and community support that we can garner, we can turn the tide. Because the good thing about behavioral health care is perhaps we have a small workforce, but we do have research, practice, and interventions that are shown when people engage with them, they do change lives and outcomes are better. So, that's a silver lining. If we can do it, we know how to do it. If you can engage in treatment, we know it works. And the struggle really is getting the access to that care.
Thank you so very much, Heather. Before we go to questions, and just a reminder that you can put questions that you have in the chat, and I will be glad to read them and see if I can fit them in with some other questions that we've stepped up and gotten going. But I did want to acknowledge, and there are a lot of people who are on phones and iPads, so I do not necessarily know who you are. If you happen to be an elected official or a candidate, and you can drop me something in the chat to let me know you're joining us, I will be glad to recognize you. But I would like to recognize our former state representative, Margaret Doherty, who is with us and a longtime member of Willamette Women Dems, and we're always thrilled to see her. And I also noticed that Nadia Hassan, who is a Beaverton City Councilor, is on the line with us. And if there's anybody else, please drop me a note in the chat if you can, and I will be glad to recognize you. Either a candidate or an elected official. So our first question really was about strategies for bringing more people into the field, but I have a couple questions associated with that. So one of them, are some of our challenges related to pay equity and or also through the university pipeline, are there really enough slots to move the number of people we need to move into this field? And Heather or Lisa, either one of you can address those.
Yeah, I'm happy to. We have been doing a lot of data collection and research over the last year to support legislative and policy action like 4004. And so we have learned a lot of things from our workforce and also from our member agency employers. And what we find is there's pretty significant alignment around when a person is in the field, why they may move on to another sector, or choose to move on to what we would call a competitor, like a government agency or hospital that has a different kind of payment structure and salary wage flexibility than the behavioral health public sector. Also moving on into private practice once they're licensed. So what we're finding is, yes, in the public sector of behavioral health, so remember when I mentioned there's a lot of different types of behavioral health. Behavioral health is kind of funny because the public sector of behavioral health really predominantly serves in the majority folks on the Oregon Health Plan. Whereas the private clinical side, like you go to a licensed clinical social worker or a psychiatrist or a licensed psychologist who has a private practice, maybe they work in a group practice, those folks tend to take commercial insurance. So there's a strange divide in our sector where there are commercial people who really serve more of the commercial side and people who really serve more of the behavioral health side. So when we talk about lack of access, as I mentioned, in those residential facilities, those facilities tend to be very heavy on the public side. And so it's very hard for those agencies to hang on to people with master's level or higher because the wages are uncompetitive. And they are also capitated within a public health plan benefit. Whereas on the commercial side, there's private pay where people don't even use their insurance to pay, or they have private insurance, and there's a different kind of payment structure that can be much more enticing and offer more flexibility and improvement in wages. So yes, wages is definitely a big piece of why people leave the public sector, unfortunately. Another piece is because of that division, what happens when you work in that public side is that the cases that you're working with tend to be the most acute services. So what I mean by that is if a person who has schizophrenia is doing really, really well, they might be going to a private practitioner and all of a sudden think it's a chronic disease that has its ebbs and flows, and perhaps they're having a difficult time and now they need a higher level of care. That higher level care actually is paid for and served in the public side. So that means that the person then shifts to that public side, which then means that all of the caseload for that the practitioners that work on the case on the public side tends to be very intense. And so that increases the risks of vicarious trauma, stress, increased caseloads. So working in the public sector has a higher level of acuity and therefore a higher level of stress for a lot of the workers. Whereas we tend to see on the commercial side that more of the clientele that is served is moderate to low level acuity. And so that's very different from the medical side, right? Because in the medical side, we try to balance, in most settings, there are settings that are not that way, of course, but in many settings, they try to balance out some folks who have high need and some folks who have low need, but our system is not designed to really deliver care in that way. So that is, we've found that is actually a stressor on our public side of the thing. So that is another reason that people leave is stress and acuity from the public health side, and then go into a higher paying job. So those are really the two largest factors that were reported from employees when we did an employee survey with a certification board, and also from employers when they do exit interviews with their staff. That we have found that those are probably the two predominant reasons for people moving out of the field. The big issue that we also see with recruiting new people is people are just, as I mentioned earlier, are just not aware that there are so many different types of jobs available to them and entry-level jobs available to them that don't require 8 or more years of education in the sector. People don't really understand what we do in the sector. They don't really understand the options that are available to them because we've been so quiet and not really talked about what we do for so many years. And so that is also a barrier to recruiting new people and talking to high school students about job opportunities and training people. And I think that is particularly true when we look at socioeconomic barriers for folks if they can't see themselves or financially achieve going to an 8-year program, and then they decide, oh, I can't ever do that, they're not going to do that. So it really behooves all of us to do a better job. And that's why we're so excited about the workforce campaign of reaching out to diverse communities and low income communities, and helping people understand that there is an achievable workforce ladder that is available to them in the behavioral health sector.
Can you talk a little bit about the work that's being done to support the schools as they're focusing in on addressing students' emotional challenges in the schools through which existed pre-COVID and has been exacerbated?
I mean, I'm happy to give my perspective, which
Sure.
which I probably have more as a pediatrician than as a legislator, but we certainly know with the Student Success Act that quite a bit of resources were devoted to kind of behavioral health, having more behavioral health personnel in the schools, incorporating, kind of what we call trauma-informed care, which to me, just to shorthand for people, so we all know what we're talking about. To me, trauma-informed care is like, instead of like, why'd you do that? Which of course I can picture myself saying that to my own kids, versus like kind of what happened to you and how can I help? Like almost, I always picture like literally getting down on your knees and looking that child in the eye. And I know as we give teachers and other school personnel training, which isn't crazy extensive, there's a lot of really great, I don't want to say tricks, but there's tools and ways to kind of make inroads with young people who are having a tough time or a tough moment. As we're able to give teachers and other adults in the school building, more tools to help with this, it all goes better. So this is something that I've certainly been encouraging, both in terms of PPS and Beaverton School District and other Washington County schools. Some of the psychologists and trainers I know doing this work have tremendous results. So I think that's we have to like almost rethink how we interact with kids, like on pretty fundamental levels. And when that happens, things get better. Now, of course, I'm seeing the questions in the chat. These last 2 years have been incredibly challenging for some kids more than others. There's other kids who've really thrived. I mean, that's been really interesting to me too. Kids who actually were tired of some of the drama in school and actually really are just kind of really motivated self-learners and are doing a really nice job. And that's just really interesting to think about that. A lot of kids who were really struggling with remote school have gotten back into the routine of being in person school and are doing really well. It just shows you the resilience of kids, which is partly what makes pediatrics so fun. I mean, one of many reasons why pediatrics is so fun. Yeah. So I mean, I think just this kind of social emotional learning kind of, should be taught just like, arithmetic is taught. And I have to say, in the old days, maybe when I was a little more conservative, I used to think, that's kind of the family's job. Well, that's not working out so well for us because parents have their own traumas and their own, I guess, triggering sometimes by kids. And I think we all can do better. So I'm excited about this kind of new way of thinking about how we interact with kids in school. And Heather, please feel free to add to that. It's easier said than done, but it's not that hard. That's, I think, what we're finding. It's not as hard. It's not this huge lift that we're all worried about.
No, I totally agree. I think we're on the same page. And there are, as I mentioned earlier, there's some really excellent proven curricula and interventions that could, if implemented at a scale that made an impact. I think that's somewhere where Oregon has often struggled, as we do a lot of little project funded by a grant here and a little pilot over there. And if we really want to lift the opportunity, because we have curricula, we have things that work, that make an impact, it's taking it to that level that actually makes a population health difference, right? And it's so exciting, these curricula like mental health first aid for adolescents. This is it's one of many well-proven curricula that teaches life skills and coping, and really helps with both substance use disorder prevention and making healthy choices. I mean, that helps with bullying and with substance use, with mental well-being. Those kind of curriculums really, when they focus on healthy choices and taking care of oneself and standing up for oneself, those kind of curricula make a huge difference for students. The other opportunity that we have in that moment, if we take it to scale in schools, is that we start really taking away at stigma, and we start educating people about behavioral health professions, just like STEM, right? You remember everybody STEM, those science programs? Well, now we have seen that those kinds of programs exposing young people very early on, grade school, middle school, high school, it gets them thinking about science in a different way and engaging in those professions in a way, especially young women and communities of color, in a different way. And I think this is really an opportunity to do this with mental well-being. If we really started doing it earlier. I was really lucky, and in the 90s, I did one of these curriculums. It was called Life Skills, and it was from Hazelden, which is a Betty Ford. A lot of people probably recognize that, substance use and alcohol disorder research and treatment entity, longstanding. And that kind of discussion really, if you have it regularly early on, helps kids really have a forum to talk about what they're thinking about and what they're experiencing. And I know, and it can really be a useful way to implement and weave into the curricula. Totally agree.
Thank you both. We have a very specific question, but it's a very important question, and that is, how are behavioral health services for kids being targeted for communities of color? Are there special challenges, and are there special programs or things, funding or whatever, to really help address, to ensure that there's equity, but also I think culturally specific, I think would also be an important factor. Would you both address that, please?
Yeah, thank you for the question, Nadia. I will say, of course, the acknowledgement of the trauma that our communities of color have experienced, again, blown open by COVID, blown open by climate change, disproportionately affected by both the disease of COVID and I think some of certainly the ramifications of remote learning. So I think acknowledging that and figuring out how we can address that or make up for that at the school level is really important. I will say, last year, Representative Janelle Bynum spearheaded a bill to really improve recruiting and training members from the Black, Indigenous, people of color communities to enter the helping fields when it comes to behavioral health. And like Heather said, it's hard to know sometimes where to make the inroad. We all probably know if you have a master's degree, it's a pretty, clear line, but there are a lot of different ways to enter this profession. And the bill, I'm really terrible at remembering bill numbers, but the bill that we passed last year put quite a few resources into focusing on training, mentoring, grants, loan paybacks, so that we can get more people from the Black, Indigenous, people of color communities in this profession. Because we know, right? We know that if you are someone in those communities suffering from mental health issues, I think your treatment will feel more comfortable and more salient if your provider who's helping you looks like you and has some shared lived experiences. So I'm really happy about that bill. We did a few tweaks on it just now, like I think today, was that today? In behavioral health this morning. So that's well on its way to hopefully making a big difference. And I hope that answered your question, Nadia. And Heather, please add to that.
Thank you very much.
You're not alone. My sense of time is completely gone.
No, we're fine for a while. I'm just trying to think what else is in some of the questions in the chat. There has been, I guess one of the questions is related to the statistics that you gave us, Heather, about the loss of inpatient and residential beds and what needs to be done to turn that around. Is that a staffing issue? Is that other what drove, that's a pretty big drop, both
It's
those numbers.
it's a multi-layered problem. And so it is all of those things that we just mentioned: staffing, competitive wages, workforce stress, and also ensuring that we have the operate. This is so weedy. I do apologize. The operational supports that nonprofits and private organizations need to deliver modern, whole family, equity focused care. And I don't want to get too in the weeds, but what I will say is a lot of the regulations and rules and requirements for these entities to operate in compliance to, many of them were written in the 1980s and layered up and not really in small changes made over time, along with the payment structures. So, nobody would want to go to their primary care doctor and say, please give me the best care using the tools that were available to you in 1989 or 92, right? Nobody would do that. And so there is a level, what we see, and one of the things that I didn't talk about that we also heard from our employers and our workforce when we did surveys, was that they're really frustrated. They get training in really modern care, graduate in 2021, and then they go out in the field and there isn't the ability for them to implement all of that really modern, exciting care that they got so excited about in school, because the system is very tiny, it's fragile, it's underfunded. And so that becomes a big frustration for people to know that they have these things they could do and they don't have the tools to help them do that. So if you layer that on top of the other two issues that we already talked about, it becomes very difficult. So one of the exciting things that we're trying to do and getting support from our Oregon Health Authority and our legislative champions is really taking a look at those operational things, which are really unpleasant to talk about, and probably nobody wants to know the nitty-gritty details, but trying to modernize those so that we can really deliver a youth system of care that's most effective. I'll give you a quick example. So back in the 90s and 80s, youth residential substance use treatment was provided by what we call a CADC. We still have those. So a person who has an associate degree in treatment, and we would take youth and put them kind of in a dormitory style treatment center, and we would give them treatment and kind of treat them like like adults. We kind of treat them like adults. And what we know now in 2022 is that actually youth still are part of a family system. They cannot be treated like adults. They have developmental needs that are very specific, and they do best when they're with their family. There's tons of research that shows us this, research for kids who've been in foster care, research for kids who've been in multiple systems. We know sometimes when we intervene well-intentioned, we actually are not that helpful. And it is very, very important to support the family system, give the parents the tools they need, and to do it in a very whole family, co-occurring, trauma-informed way. And especially if you're working with particular culturally responsive services and culturally specific services, you have to layer in a whole nother cultural approach that is less westernized in its medical approach for people to really engage as a community and wrap around that individual and that family to support them. So we have a lot of work to do to figure out how to audit that kind of a program, how to support that kind of a program, and how to pay the workforce that delivers that kind of a program. But we are chipping away at it because we know that these models work. It just behooves us as the people in leadership to find a way to support it. And I guess that's a long story short, but that is a big part of trying to lift the work and making it a healthy, effective, and exciting place for people to come to work, and that is effective in its treatment and meeting people's needs, especially our BIPOC communities.
Okay, we are getting so many wonderful questions and I can't quite keep up with everything, but I do want to particularly ask this question that came from our committee, and that has to do with rural situations, rural health, and telemedicine, which is just a whole new growth area, I guess I will call it, certainly on the medical side. And so what's happening with behavioral health, both in our rural communities and in terms of telehealth? Is there some work being done there.
I mean, certainly we know that when we all pivoted to telehealth in COVID, and I will tell you, as a pediatrician, we're like, what? We're not going to do this. And of course, we all love it. I love it. And my families love it. And I joke that I get to meet the kitten and I get to see the art project. So I have found it really rewarding to do telemedicine with patients. And it certainly lends itself to do my version of behavioral health visits when I'm doing a check-in on a depressed teenager, to do it remotely. I've had a lot of kids who said they just don't want to do therapy remotely. And when we're in the middle of COVID, I'm like, too bad. You're going to have to, kind of like we don't have an option. So I know there's been a hesitancy to do some behavioral health stuff remotely. And I certainly understand the value of being in person with a therapist, but I think telehealth is going to be a boon for places in rural Oregon where we may not have the actual bodies doing the care. I mean, we still need to grow our workforce, but I don't think it's any coincidence that these apps have grown up, have become very popular, where you can literally tap in your app and you can talk to a mental health provider almost on demand. And I think it's great. I want to do a little more research into it. But there are times when we're having a tough time in life where you don't need a 6-month therapeutic relationship with a one-on-one therapist. I do think this model of the 90-minute intake one-on-one with a therapist to start treatment is a real barrier. We don't have enough 90-minute slots to start treatment for everyone who needs it. So we have to get creative, whether it's through telehealth, whether it's through 20-minute visits, whether it's through group therapy, because a lot of those are better than nothing. And a lot of those might even be better than the 90-minute intake one-on-one, to be perfectly honest. So I would just say that I can think that telehealth is only going to really help access for everyone, let alone in rural Oregon.
First of all, I want to welcome somebody who joined us a little bit late, Catherine Harrington, who is the chair of Washington County Commission and also a candidate for re-election. And she noted in the chat that our governor is committed to racial equity, including expecting the Oregon Department of Education and the Oregon Health Authority to work to improve behavioral health for communities of color. And her question is, how can the legislature ensure that commitment continues under a future governor so that it's not just a goal, I hate to be crass, but like a political goal, but there's no there when time passes. So is this something that's coming up in the legislature?
Absolutely. I mean, number one, we have to elect a Democrat as governor. No question, no ifs, ands, or buts. So everyone get ready. We can wait till after the primary, but whoever gets elected as Democrat, we all have to work very hard to keep a Republican and I think Senator Johnson out of the governor's seat. I'm going to be very partisan about that. I certainly know Tina Kotek is incredibly dedicated to this cause. I don't know as much the other candidates. I'm not saying they're not. But I do think that the bill I mentioned earlier, where there is a structure in place for a pipeline that will really help kind of grow more people in the profession, in the behavioral health profession that come from the communities of color. I think that's a really important start. I hope that answers the question. And I think same goes with schools. We need more adults from communities of color in the schools, whether it's teachers, counselors, principals, of course, so that kids can see themselves in those roles going up. And yes, absolutely. I'm seeing all this stuff about social determinants of health. I will say the CCOs have done a good job at putting front and center. I will say in my clinic, we ask all the time about food insecurity. We ask about parents' ACE scores, which is adverse childhood events. We know that if a parent has had significant adverse childhood events, it impacts their ability to be the best parent they want to be for their kids. So we get that parent into treatment and into counseling. We talk to parents of newborns about this. So I think I will say pediatrics has really changed on this route. We used to just talk to parents about ear infections. No, we don't even see ear infections anymore, thanks to those masks. But and thank you so much, Carol, for the Oregon Youth Line, the Teen to Teen. One other thing, one note I just wrote down is like, ask the kids, right? You know, and I think we need to keep asking kids, what can we do to help? What can we do to support? The Lines for Life group, oh my gosh, there's so many high school kids that volunteer for Lines for Life. I think we need to really plumb those kids and figure out, you know, those are the experts, both in what they're experiencing and what they're hearing from other kids. So we absolutely, I feel like that's a little bit untapped, at least at the legislative level, and something we need to probe into.
Absolutely. And I totally agree. I think that as advocates and providers in the system, we will continue to advocate and support our legislators and our health authority in delivering health equity. Being on the ground and seeing the need, it is top priority for our membership, and also that we have so many culturally specific and culturally responsive programs who are overwhelmed with wait lists, and they are ready to train more people, create more access. You know, they live it every day. Folks are representative of their communities, and they are so excited to see this momentum, and we are 100% in advocacy behind those efforts, and to continue to do those programs and make sure that we have knowledge and awareness, so that not only can we serve communities, but also that we can increase the work pipeline to different professions and different adult support roles to meet the need across the state. And one thing I would say about telehealth is absolutely phenomenal. And one of the biggest gaps, and we haven't talked a lot about the public side, though I see so there's some questions about that for folks who are not on Oregon Health Plan and folks that perhaps have episodic or short-term low to moderate mental health needs. There is a huge market of tools that Representative Reynolds just mentioned that are so effective for folks, and just the research is just coming out to be so useful for folks that really don't necessarily need an acute, we call it acute in the field, when they have representing with a really severe situation, that people can get the right service at the right time. And telehealth is a tool that is really helping us, because with the workforce shortage, to get the right service at the right time. But I do caveat it that one therapist, whether they're in person or in telehealth, can only see so many people. So telehealth does not, even though it's telehealth, it still requires a person, unless it's a self-maintenance or self-help app, right? So many of those even have peers connected to them, which is just super exciting. But I do say we still must forge forward in our workforce recruitment and diverse workforce recruitment, because even on telehealth, one clinician can only see so many people.
Yeah, great.
Yeah.
So we have another question, and I think you somewhat related to this, Heather, but who accepts young people who are not living at home and who do not have insurance? We certainly know, I know Beaverton gets the numbers all the time, but it's not the only community. We have a number of youth who are in high school and are housing insecure. So they may not be on the street, but they're moving from place to place. They're not home with their families. So who helps them? Where do they go?
There is a sector in our behavioral health continuum of care that provide shelter services for youth, that provide support services, help with emancipation if that is a need, help with employment and housing. Those are usually under shelter or social services. And there's a myriad of those agencies across the state. There definitely is not as many as the need would have, and sometimes they're hard to find because they're not under a mental health hospice necessarily. They're part of shelter services or social determinant services. That kind of gets back to, sometimes it's hard to find a service even if it's there because you don't know where to look for it. And so a good place to connect with that is, if you have a question, you can always reach out to Oregon Council for Behavioral Health. There is also another association that actually represents youth shelters, and what we call therapeutic foster homes. And they also do a lot of supported housing for youth who are not with their parents. And that is the Oregon Alliance. So if you just look up Google Oregon Alliance, they will get you connected to a service in your community. And what I say is reach out if you are working in a school or if you're a board member, reach out and ask those folks to come to a presentation about how to access their services and what they have to offer. And heck, they'll work with you to even develop more services. So, this is really, it takes many hands to build a system. And we, that's what I'm so excited to be here today and to see your interest, because we need all of your support, your volunteerism, your participation, the sharing of knowledge to really make this happen in a more expedient way across the state.
And just one question, and I think it's sort of on the edge of this issue, but a question to you, Representative Reynolds, is what advice do you give parents about social media and the extent to which social media impacts health, and both physical and mental health?
Yeah, you see it's a tough one. I mean, it isn't tough. It's tough in the fact that it's hard to get our kids and even ourselves off it. There's no question social media exacerbates, if not even sometimes causes depression, the whole comparing yourself with others. There's also some, there's a piece in the New York Times a couple months ago about some of these kind of, there used to be there are these sites about anorexia nervosa that actually kind of draw people into developing eating disorders. Well, there are websites around suicidality that can actually draw people into those feelings and behavior. And I know it sounds a little oversimplified, and I am oversimplifying, but there's definitely a lot of perils in social media, both in terms of exacerbating or causing, especially depression and probably some anxiety. There's some good things about social media, right? It's how a lot of kids stay connected to their friends, especially during COVID. So I guess I would have pretty serious conversations with your kids to take breaks from social media, see if it makes them feel better or worse. Most kids, if they are pushed or forced to get off social media for a spell or for a period of time, realize that, oh, wow, I am actually feeling better. And they start making different decisions. But it's tough. The people who design these apps are brilliant, and they design them to be addictive, and they design them to be kind of percolating in your head. And it's why, the people who built, the social networks are, tell their nannies and babysitters to never let their own kids get on them, because they understand the addictive nature. But it's a real problem, and I don't have an easy solution, except we'll never regret kind of putting our foot down and live on this as best we can with our own kids.
Well, I want to thank you both. Wonderful discussion, wonderful questions. Thank everybody for their questions. I think we hit the vast majority of it, maybe not everything, but only so much time. So thank you both very much. I do also want to welcome Catherine Mullen, who is a candidate for the Clackamas County Clerk and joined us a bit into the program. And so I'd like to talk a little bit more about what's coming up in the next several months, because May elections are getting close, and we are going to be focusing on them in both March and April. So in March, we look forward to seeing you as we invite the two leading candidates for Labor Commissioner, Casey Kula and Christina Stevenson, who will be joining us to talk about the position and why they're running and their visions. We're also thrilled to be welcoming the new Speaker of the Oregon House, Representative Dan Rayfield, to W2D. He will give us a very quick overview of the just concluded short session and a look forward into the upcoming elections. So please watch for our program announcement for that. In April, we will then be inviting a number of candidates who are running for positions across the counties to come and join us for very, very brief presentations, mostly because there's a lot of them and not a lot of time. But we want to get them in front of you, get you thinking about it, and really talking with your friends and neighbors. Local elections are so important. They really make a big difference in our day-to-day lives and and really support our community. So what happens in our county and in our city, we have some races there. So important. So I really hope that you will take the time to join us in the next 2 months and start meeting some of these wonderful candidates who are running for office. So thank you all for joining us. Be sure you are fully vaccinated, boosted, follow health and safety guidelines, and stay well. And we do look forward to seeing you all in March.
Thank you all so much. Thank you. Nice to see you, Heather. Thank you, Veronica and Nancy. Thank you.
You're very welcome.
Great
Thank you
questions.
both.
Thank you.